Hello everyone, welcome to HIM 216. This is a continuation of our lectures for Chapter 6. In your textbook, if you will, please turn to page 126. And we're looking at Guideline B37, which concerns the use of the root operation of control versus a more definitive root operation. And basically this guideline defines control for us, stopping or attempting to stop post-procedural bleeding. And if that attempt is unsuccessful they have to perform another procedure to stop the bleeding, such as a bypass or detachment, excision, extraction, reposition, you can see those listed here, then that definitive root operation is what's coded and not just control. Now, in the example we have, it's resection of spleen to stop post-procedural bleeding. And if we look in the medical surgical section, the spleen is part of the lymphatic and hemic system, and in this example they have performed a resection of the spleen. That's our root operation. The operative report would tell us that they actually removed the spleen, so we would know they removed the entire spleen. And then for the body part, you can see that P is the body part for spleen. This is an open approach and there's no device and no qualifier. So this code would be 07T P0ZZ. And if I were writing this, I would be putting a line through my 0 so I'd know it was a 0 and not an O. And then I would also be putting a line in this Z so I would know it was a Z and not a 2. So that when I was writing it, it would be very clear to me what my characters were. Now, I want to demonstrate, if we look up the root operation control, you can see control post-procedural bleeding in. And let's say that we want to look at a tonsillectomy, and sometimes that tonsillar bed will bleed and they will take that patient back to surgery and just use cautery and cauterize that tonsillar bed. And that is actually an example of a good example of control. And we can see that from the index it will send us to table 0W33. And this approach is considered to be external, no device, and no qualifier. So this is the this would be the code for like a tonsillectomy, and they have to go back in and cauterize that tonsillar bed. If we look at this just from the table, and we go to, let's go to mouth and throat, and then we want to hit control. Where is it? Well, it's not there, so mouth and throat is obviously not where I need to be here. Where I need to be is anatomic region general. And when I go to anatomic region general, I will see change. I don't want change. I want control, and then oral cavity and throat, and then external, no device, and no qualifier. So let's look at excision versus resection. Now, this is talking specifically about body parts that have subdivisions. And so examples of these are the lungs. So we're going to look at the lungs. So we're going to be in the respiratory system. And we're going to look at resection. Now, remember that resection is when we take out all of a body part, but there are certain organs in the body that have distinct divisions and distinct areas: the lungs, the liver, the colon. And if you'll look under this root operation of resection, we have lower lobe, upper lobe, middle lobe. And when a lobe of the lung is removed, rather than it being an excision, which remember is part of a body part, let me just go and choose excision. You can have an excision of a part of the right upper lobe, but if the entire right upper lobe is removed, it is a resection. For instance, there is something called a wedge resection, and if the wedge resection, it's when they just take out a little wedge of a lobe of the lung, that is considered to be an excision. But if they remove the entire lobe of the lung, then that is considered to be a resection. And this same guideline actually applies to the liver, and that the liver's in the hepatobiliary system. So if we go to resection, we can see the right and the left lobe of the liver. But also we can have, we can also have an excision of the right and left lobe of the liver. If they only biopsy either the right or the left lobe, then it's an excision. But if they take out the entire lobe, then it is a resection. Many times lymph nodes are removed as a part of a procedure, and when lymph nodes are removed, that is an excision unless they remove the entire lymph node chain. Now, if they remove an entire chain, then you code to resection, and they will tell you that's very extensive surgery, and they will tell you that they removed the entire lymph node chain. I have seen them document that they removed as many as 15 or 17 lymph nodes, but they did not say that they removed the entire lymph node chain. And so in that instance, we would actually be talking about an excision as opposed to a resection. So be very cautious of that. We will have some examples of that. So just remember, lymph nodes, unless they document they removed the chain, it's an excision. But if they document that they removed an entire chain, it is a resection. Now the example we have here is left upper lung lobectomy. And so in this example, they took out the entire left upper lobe. So we're going to be, our body system is going to be respiratory. And our root operation is going to be resection. And then this is the left upper lung lobectomy. So upper lung lobe left. And this would be an open procedure with no device and no qualifier. So our code is 0BTG0 So your first question for this lecture is, if in fact the documentation stated that the right lobe of the liver was removed, how would you code that? What would the code be for the removal of the right lobe of the liver? Guideline B39 is the guideline for a graft. Now, autograft, that means it was obtained from the patient. When you see terms like this, if you don't know what they mean, you need to look them up. So an autograft, so this means it was obtained from the patient. If it's obtained from a different body part to complete the procedure, then a separate procedure code is coded. And the example for this is a patient that comes in to have a coronary bypass, and they actually end up harvesting saphenous vein to complete that bypass, and that is very commonly done. Now, the example of this is the excision of the saphenous vein. And when a coronary artery bypass graft is performed, they're literally bypassing coronary arteries with other tissue. They're bypassing the blockage, and we'll look at that extensively when we're in that chapter in our textbook. But if we were going to code these, we would be looking at lower veins. Our body system would be lower veins because the saphenous vein is in the leg, and that's where they get it. And they would not take out the entire saphenous vein, so the root operation would be an excision. And you can see that the options are either the greater or the lesser saphenous vein in either the right leg or the left leg. And usually they take out a greater saphenous. And I would say probably of the left leg. Sometimes this is an open procedure, sometimes it's percutaneous endoscopic, and you just have to read the operative report to know what the approach is, and then there's no device and there's no qualifier. So typically for that harvesting, and they call it harvesting, for harvesting that vessel, the code would be 06BQ0ZZ. Now we're going to talk about fusion procedures. And I want to preface this by saying I would not expect you to go to work in a facility as an inpatient coder and be given any type of fusion procedure record chart to code without first getting some education and having someone who codes them routinely sit with you and go over these guidelines. But if you find that you are coding fusions, make sure you come back and read the guidelines before you start coding those fusions. Now, there's actually a root operation of fusion, and when they fuse, they fuse joints. So obviously we would be in medical surgical, and then it would depend on what joints they were fusing as to whether or not you would choose either upper or lower joint. And that, even, remember, below the diaphragm is a lower joint. So if we look at upper joint and we choose fusion as our root operation, you can see that we have cervical and thoracic vertebral joints listed here. Now, if we go back and we choose lower joints and we choose fusion, you can see that we have lumbar and lumbosacral coccygeal joints listed here. So if you don't find, if you're not sure, well, is that above the diaphragm or below the diaphragm, you can look at an anatomic chart to try and make that determination, but otherwise go into upper joint. If you don't find it, go into lower joint. Now, as we look at these guidelines, it tells us that there is a distinct body part value for a single vertebral joint or for multiple vertebral joints at each spinal level. So if we look at lumbar vertebra, we're going to see joint, that means one, joints two or more, so that's two or more vertebral joints. Let's go back into upper joints. And you can see we have cervical joint 2, thoracic vertebral joint, thoracic vertebral 2 through 7, and thoracic 8 or more. So that's how those body parts are defined, is by the number of joints that are fused. So that's one of the things that you have to know when you're coding, is how many joints were fused. And certainly the operative report will tell you. And then this example we have is a posterior spinal fusion with L1-3 with a BAK interbody fusion device and morcellized bone graft from the operative site. So we're not going to code that until we finish looking at these fusion guidelines. B310B tells us that if there are multiple vertebral joints fused, but there's a separate procedure, then each one of those is coded separately. And we have an example here, and there are 2 procedures listed here, and I actually put parentheses around them so I can help separate them visually when I read them. The first procedure is fusion of lumbar vertebral joint, posterior approach, anterior column. And then the second one is fusion of lumbar vertebral joint, posterior approach, posterior column. Now I want you to look at the qualifier. And the qualifier is actually, when we look at this example and we see posterior approach, anterior column, do you see that J is posterior approach, anterior column? And when we look at the second example, posterior approach, posterior column, 1 is posterior approach, posterior column. So the qualifiers are distinct in these 2. So you would have different codes because of the distinct qualifier. Now let's look at B310.C. And when spinal fusions are done, there are different devices that can be used. And that's this 6th character, which is device. We'll click on it, and you see that it gives us examples of autologous tissue substitutes, synthetic substitutes, non-autologous tissue substitutes, and this includes things like bone bank, bone graft, tissue bank graft. Synthetic substitutes obviously are man-made. And of course tissue can come from the patient as well, autologous tissue substitute. So when we're looking at these guidelines, what they're talking, this guideline is talking about the devices. One of the things that can be used is an interbody fusion device. And you'll see that that is A under device, interbody fusion device. Now, if they use an interbody fusion device to immobilize that joint, and they use other material with it like bone graft, the only device that we code is the interbody fusion device. So if that's what's used, it takes precedence over the others, and that's the only device that you use. Now, if bone graft is the only device that's used to make that joint immobile, then we code that to non-autologous tissue substitute or autologous tissue substitute, and it depends on where they get the tissue. Is it from the patient or is it from another type of a donor, maybe a cadaver donor? If they have a mixture of autologous and non-autologous, then we code it to autologous, to an autologous tissue substitute. And so on the top of page 127, they have this example, fusion of a vertebral joint using a cage-style inner body fusion device, and that's A right here, containing morcellized bone graft. We code that to the inner body fusion device. It doesn't matter whether they used bone graft or not. It's coded to inner body fusion. And then we have fusion of a vertebral joint using a bone dowel inner body fusion device made of cadaver bone, and it's packed with a mixture of local morcellized bone and demineralized bone matrix, and this would be coded to the inner body fusion device. So even though they had all this other material, because they used an inner body fusion device, that's all that matters here. When you read this and you say, oh, inner body fusion device, it doesn't matter what else they used. We code it to the device inner body fusion device. Now, if we have fusion of a vertebral joint and it uses autologous bone graft and bone bank bone graft, we code that to autologous tissue substitute. So that is 7 when we look at the devices here. Okay? So now let's go back to question 14. We have a posterior spinal fusion with L1 to L3 with an inner body fusion device and morcellized bone graft. Well, we already know the only thing we're going to worry about is the fact that we have an inner body fusion device that is used. And this is actually going to be in lower joints. And we know that our root operation is a fusion. And this is lumbar joints, 2 or more. It's L1 to L3, so that is 2 or more joints. This is an open procedure, and we have an inner body fusion device that was used. And does it tell us the approach? No, we're using anterior approach. No, we're using it doesn't tell us the approach. We're just going to say anterior approach, anterior column. And if we were reading the operative note, we would know exactly what the approach was. I guess we could, no. We either have to choose 0, 1, or J, and we're just going to choose 0. Okay, so it was 2 or more vertebrae. It was an open approach because it doesn't tell us anything different, and it was an inner body fusion device. Okay, so now let's go, let's look at B311A. If there is an inspection of a body part and they do the inspection in order to do another procedure, that inspection is not coded separately. Now remember that we do have a root operation for inspection. So for instance, if a fiber optic bronchoscopy is performed and that's it, that is an inspection. And we can actually, let's see, we can actually put in bronchoscopy, and it will send us to this table: medical surgical inspection, tracheobronchial tree, natural or artificial opening, ZZ. But in the example we have for this, an irrigation procedure was performed. Now, we have a root operation for irrigation. It is not in medical surgical. And this is actually an irrigation of the respiratory tract. It takes us to table 3E1F. So 3 is administration, which we'll study in chapter 7. And here is our root operation. We choose 1. And then we choose F for the respiratory tract. And then our approach would be via natural or artificial opening endoscopic. And we have an irrigating substance, and there is no qualifier. Now, I will tell you that usually if a bronchoscopy is done and they do washings, it's diagnostic. They're sending that material, that irrigating substance with the cells to be evaluated. Sometimes they're looking for cancer, sometimes they're looking for an infection. So you would really be reading the operative note and looking at the path report to see what the intent of that procedure was. 311B talks about tubular body parts that are inspected. Now, think about a tubular body part. It can be your esophagus, it can be your colon, it can be your bladder and your ureters. You code to the farthest away. How far did they go? So in this example, it's a cystourethropy. So this was examination of the bladder and the ureters. And so we code it to the body part value for the ureters because that's as far as it went. And then also, if we have multiple non-tubular body parts in a region that are inspected, then the body part specifies that entire area. And we have an example here of like an exploratory laparotomy, and that's when they go into the abdomen, they cut open the belly and they look. Usually when they do something like that, they're looking for causes of cancer. Sometimes they'll open a patient up and they may have such extensive metastasis that they don't do anything, they just close them up. But there may be different reasons that they perform that. So let's look at these particular examples. So if we look at question number 16, diagnostic cystourethropy of the bladder. So we're going to be back in medical surgical. And then we're talking about the urinary system. The bladder and the ureters are in the urinary system. And we're doing an inspection. So nothing else was done, but they just went in and took a scope and went in and looked at all those body parts. And we're going to choose the ureter. And this was via natural or artificial opening endoscopic, and there's no device and there's no qualifier. So now when we are talking about the exploratory laparotomy, we're in medical surgical, but now we are talking about an anatomic region. And this is not an upper or lower extremity, so it's an anatomic region general. And our root operation is the inspection. And the body part for this is the peritoneal cavity. And this is open, no device, and no qualifier. So for this exploratory laparotomy, our code is 0W-JG-0ZZ. Now, the next question for you for this lecture is, I want you to define the difference between a laparotomy and a laparoscopy. So what's a laparotomy and what is a laparoscopy? Define those two. And then the final guideline that we're going to go over in this lecture is B3.11. And this tells us if there's an inspection procedure and another procedure performed on the same body part during the same episode, if the inspection's done using a different approach than the other procedure, then the inspection is coded separately. So they're distinct procedures, and the example of this is an endoscopic inspection of the duodenum is coded separately when an open excision of the duodenum is performed. So let's say that they go in and they use a gastroscope, they go down, they look at the duodenum, and then they decide to perform an open duodenectomy. And so what we would be coding here is two procedures. So we would be in medical surgical, and then gastrointestinal. The duodenum is part of the gastrointestinal system. And then we would be coding the excision of the duodenum, be an open approach, no device, no qualifier, 0DB90ZZ. And then we would need to code the inspection of the duodenum. So we're still in medical surgical, we're still in gastrointestinal, but our root operation becomes inspection. And we are now looking at our body part will be the upper intestinal tract. So if we get here and we like, oh my gosh, where's the duodenum? If I click on body part, well, that's not particularly helpful. But it's going to be upper intestinal tract. And it's via natural artificial opening, and there's no device and there's no qualifier. So 0DJ08ZZ. That will conclude this lecture for Chapter 6, and for our next lecture, we'll be picking up at B3.12.